Histologically, it's very difficult to distinguish, because if you get just the histological part of a tumor of upper urinary tract or the bladder, you cannot distinguish because they really look exactly the same. In the surgical pathology part, we know from a molecular point of view that the urothelium in the upper urinary tract is pretty different because it does different movements. Can you say that in English? And it's strictly the same. We have some conic scenes which are present in the bladder, but which are not present, for example, in the upper urinary tract, and so on and so on. From a molecular point of view, we have very many FGFR3 alterations, most of the mutations in the upper urinary tract, which we do not have in the bladder. In the bladder, it's really a very small amount. It's, let's say, less than 20% of papillary tumors really have an alteration of the FGFR pathway, where we know that we can treat them. They don't always react. On the other hand, we know that really more than 70% have FGFR3 alterations in the upper urinary tract, which is pretty interesting. And they have more favorable outcome as well in the bladder as in the upper urinary tract, by the way. We also know that we have very few RB1 mutations, alterations, and TP53 alterations in the upper urinary tract. When they have these kind of alterations, they're more likely to recur. So they're more aggressive. And we also know that the high and the low-grade tumors do not exactly look the same. They do not have exactly the same molecular profile, of course. We also know that if you have an upper urinary tract and then you have a bladder tumor, they're always clonally related. So probably there's some kind of dissemination, which is not very well elucidated at the very moment. So at least we know these are clonally most of the time. No, they're always related, by the way. I will also talk tomorrow a little bit about the testing of biopsies, because, we hope when you do the biopsies in the upper urinary tract, you have very, very few cells. And very often it's really extremely complicated to make the right diagnosis. There was a very nice study which could show that even if you have very small biopsies, in more than 90%, you can do some testing. And this could, of course, guide you in the treatment. So if you have already some, not only the surgical pathology report, but also the molecular part, you can see whether this has a FGFR3 alteration, for example. And in this case, of course, the patient will be treated maybe with some organ sparing. If, on the other hand, he has an overexpression of RB1, of course, you will not do an organ sparing, even if it's not invasive on the biopsy. So there are some differences, of course. Sometimes if you have as well in the upper urinary tract as in the bladder tumor, probably it's more or less the same history. There have also been studies which could show that if these patients have metastasis, then the metastasis sometimes look much more like the bladder. So there's, of course, a kind of clonal movement, changing, heterogeneity, whatever you want. But in the end, to finish with surgical pathology, so we know that many bladder tumors have subtypes like micropapillary, nested, and so on. These subtypes are extremely rare. In the upper urinary tract, you have less than 2% these subtypes. On the other hand, we can find patients with the Lynch syndrome in the upper urinary tract, which is about found, well, let's say, you have 2 new cases for 100,000 people in the population, which is a pretty rare tumor. But it has to be detected because in these cases, of course, you have to test all the family if you have a Lynch syndrome, because you can have, of course, upper urinary tract, but you can also have endometrial carcinoma if you're a woman, and colon carcinomas, and so on and so on. So it's something which is pretty mean, although it sounds pretty nice.